The Vital Surgery Training Program is a flagship initiative of the Global Surgery Lab, a section of the Branch for Global Surgical Care at the University of British Columbia. I'm Sharza Jaharifard, a pediatric surgeon at BC Children's Hospital. My colleague is Emily Yosh, a trauma surgeon at Vancouver General Hospital. In addition to our clinical work in Canada, we each have extensive experience working as surgeons in low-resource settings, predominantly with Médecins Sans Frontières or Doctors Without Borders. Together, we lead the Global Surgery Lab, as well as the Vital Surgery Training Program. VitalSurg is a task-sharing surgical training program created for low-resource settings. Task sharing is an innovative solution to solving the surgical workforce problem. Broadly speaking, task sharing involves training non-specialist doctors in essential surgical skills so that they can share the load for surgical provision, especially in rural and remote areas. While task-sharing programs represent a newer approach to responding to the surgical workforce shortage, they are not untested. A well-established example is the Kappa Care training program, which was launched in 2011 in Sierra Leone. Graduates of this 3-year training program are recognized by the Sierra Leonean Ministry of Health and in extensive studies have been shown to provide safe surgical care in their communities. In fact, one study showed that the mortality for some procedures was lower in the hands of Kappa Care graduates than in those of fully trained surgeons. Our experiences working as surgeons in conflict and post-conflict settings in sub-Saharan Africa inspired us to create the Vital Surgery Training Program. While Emily and I undoubtedly saw the immediate impact of our work on our patients, we felt frustrated that we were not improving the capacity of local providers to deliver safe surgical care. VitalSurg was born out of this desire to leave a lasting impact on surgical care provision long after our departure. VitalSurg teaches non-specialist medical doctors essential surgical skills in places where there are few or no surgical providers. By providing context-relevant surgical training in situ, where our trainees already practice, VitalSurg aims to close the gap in surgical care in medical deserts. The goal of the Vital Surgery Training Program is to empower medical doctors to perform safe surgical care in their local context. By the end of the VitalSurg Training Program, learners will acquire proficiency in clinical diagnosis and operative and non-operative management of surgical diseases relevant to resource-limited settings. They will also gain leadership skills for effective communication and crisis resource management and learn how to become strong advocates for their patients. They will be able to critically analyze surgical cases within resource constraints, adhere to ethical principles, and collaborate with interdisciplinary teams to provide patient-centered care. Our educational team recognizes learners as individuals and respects unique learning styles. We are aware of our positionality as specialist physicians from high-resource settings and are cognizant and respectful of the existing knowledge and expertise of our learners. Specifically, we know that we are working with experienced physicians who understand the resources, pathologies, and culture of their workplace. Hence, we truly consider this experience one of bilateral exchange. This diagram summarizes the Vital Surgery Training Program, which is divided into a 10-month foundation phase and an 8-month consolidation phase. We begin the training with a 1-month-long boot camp, during which trainees learn foundational techniques and non-technical skills. During the remainder of the foundation phase, trainees complete didactic modules while concurrently training in the hospital. 1 afternoon per week is reserved for weekly lectures and simulation. During the consolidation phase, weekly lectures and advanced assigned readings continue, but greater emphasis is placed on mentorship for practice and increasing trainee independence. The last month of the consolidation phase is the capstone rotation. Here, trainees integrate into district hospitals under the supervision of an MSF surgeon. Following completion of the training program, graduates will have access to ongoing mentorship from surgeons. Now, let's dive into each component of the training program in more detail. The didactic component is comprised of 10 modules that address core competencies for non-specialist doctors practicing in rural or remote settings. 1. Safe surgery. 2. Airway and basic anesthesia. 3. Trauma resuscitation and bleeding control. 4. Source control. 5. Acute abdomen. 6. Fracture management and basic orthopedics. 7. Burns. 8. Pediatric surgery. 9 obstetrics and gynecology, and 10 urology. Each module is led by a surgical specialist with experience working in low-resource settings. This individual organizes the live weekly lectures and acts as a remote resource for trainees. During each module, trainees read online content and complete pre- and post-module quizzes. Modules are not meant to replace a textbook. Rather, they are designed as concise and interactive summaries with supplemental diagrams, tables, and other media. The modules include descriptions of all 44 essential surgical procedures as outlined by the World Bank. These descriptions are further supported by short 5 to 8 minute videos that demonstrate how to perform key surgical procedures. To date, we have filmed over 25 videos in our UBC Cadaver Lab. The weekly lectures are designed to give learners an opportunity to discuss cases, ask questions about the module content, and learn from subject matter experts. We encourage trainees to come to each lecture well prepared with questions related to the module content or with relevant surgical cases to discuss. In turn, learners should expect to have questions directed at them by the instructor. This way, we maximize active learning opportunities and enhance knowledge retention. Trainers are encouraged to highlight basics, minimize the number of slides that they present, and keep discussions case-based. Further, trainers are encouraged to make their lectures as interactive as possible. Finally, trainers are reminded that English is typically not trainees' first language, so we encourage you to speak slowly and clearly. Trainees will receive a tablet at the beginning of the program in order to access all training materials and to facilitate trainee evaluation. Tablets are pre-loaded with modules, textbooks, and videos. In addition, the tablet can be used to connect to the weekly virtual lectures. Trainees are expected to enter all cases into an online case log. Tablets will also be used to complete pre- and post tests, exams, and formative evaluations called Entrustable Professional Activities, or EPAs. More on these later. The practical component consists of hands-on training and simulation. Trainees rotate through different departments in the hospital or in a partner hospital so as to ensure exposure to all relevant specialties. VitalSurg is founded on Competency by Design Medical Education, or CBME, which is a new method of training and evaluating doctors that has been implemented throughout the world. The keystone of CBME is Entrustable Professional Activities, EPAs, which are the key activities that graduates of a particular training program must be able to perform independently. Importantly, EPAs include both technical and non-technical skills. Together with our partners, we have designed 63 EPAs for the VitalSurg program. Trainees are regularly evaluated by their supervisors on the basis of EPAs. Here you can see Dr. Anna, an MSF obstetrician gynecologist, evaluating Dr. Joseph, a South Sudanese trainee, after he performed a surgical procedure. As you can see in the photo, the evaluation occurs using an online form on a tablet, which facilitates ongoing monitoring and evaluation. We will now walk you through an example EPA. This particular EPA is for an appendectomy. As you can see, we have distilled the procedure into 6 critical steps. For each step, the evaluator will determine if the trainee has achieved that milestone. The culminating piece of every EPA is to evaluate the trainee's overall performance on a standardized 5-point scale. 1, I had to do it myself. 2, I had to talk the trainee through it. 3, I had to prompt them from time to time. 4, I needed to be there just in case. And 5, I didn't need to be there. We have found that this is a quick and natural way for surgeons to evaluate trainees. As trainees, your responsibility is to request an EPA from your supervising surgeon immediately after completing a surgical procedure. By being proactive, you will ensure that your supervisor provides you with timely feedback. To pass an EPA, trainees must achieve 3 scores of 4 or 5, meaning that the supervising surgeon had to be there just in case or didn't need to be there at all. You must pass all 63 EPAs to graduate from the program. As trainers, your responsibility is to prompt learners to complete EPAs after completing a surgical procedure. We encourage trainers to ask trainees for their impression of how the procedure went, then discuss all milestones and give a final score. You will also be prompted to enter free text comments on the EPA form, which will be useful additional information for the Competency Committee. Please refer to the short video that shows a simulated EPA procedure. In addition to EPAs, competence is also measured by online case logs, pre- and post-tests for each module, and regular written and oral exams. Trainees are required to record every single surgical procedure that they participate in for the entire duration of the 18-month training program. This allows us to evaluate the volume and breadth of procedures encountered by trainees, to identify gaps early, and to plan mitigation procedures if gaps exist. The learner will be asked to enter the diagnosis, procedure, and importantly, their role in this procedure, be it observer, assistant, primary surgeon with supervision, or independent surgeon. This information will be key for the Competency Committee. Trainees are rigorously evaluated. Trainees will complete multiple assessments over their 18 months in the training program. On the first day of boot camp, trainees will complete a pre-assessment to test their baseline knowledge. Results from this exam will set a baseline and help identify any gaps that could affect successful program completion. Throughout the program, learners will complete pre- and post-module quizzes. At the midpoint of the program, learners will participate in a midterm assessment, and at the end of the program, learners will complete a final oral and written examination. A competency committee composed of the Vital Surgery Program Directors, MSF surgeon trainers, module leads, and surgical reference will meet every 3 months. Competency Committee meetings evaluate trainees' progression, collating quiz and exam results, case logs, EPAs, and clinical feedback from surgical trainers. At the end of each of these meetings, the committee will decide if the trainee is on track for the training or whether they need remediation in certain aspects. The head of the Competency Committee will then meet with the trainees individually to give them feedback on their performance. Adjustments to the rotation schedule, additional teaching materials, or exams can be organized as needed. After 10 months, trainees will complete written and oral exams. Following this, the Competency Committee will meet and determine each trainee's eligibility for promotion to the consolidation phase. At the end of 18 months, trainees will complete final oral and written exams, and the Competency Committee will meet one final time to assess readiness for graduation. Successful candidates will receive a certificate and begin their practice as physician surgeons. Thank you for your attention and support. For more information, please contact us by visiting our website, sending us an email, or following us on social media. We really look forward to working with you.